Keep your microphone muted and cameras off. We have a team member and experts monitoring the chat section, so they will respond to your questions as needed and also be able to interrupt the speakers to answer those questions on the fly. If there's additional information or you want a quote of anything you see today, please put your email address and the name of your institution into the chat box. For the agenda today, we're going to be having Dr. Jared Marks as our keynote speaker. He will be presenting on innovative ultrasound and cloud-based distance learning. After which Ron Weiss will do a demonstration of the newest remote technology as Dr. Mike Marks guides us through a remote examination of a simulated COVID patient. I want to thank the SSH group committed to enhancing the quality of healthcare, who we can all agree has really risen to the occasion through these webinars. Introduction of Ron Weiss. He's a 3D Systems Simbionix engineer by training and education, a senior product manager of the ultrasound. He will be presenting our newest marvel of technology and the latest iteration of our Ultrasound Mentor simulator, allowing for remote learners to be hands-on with the simulator. Our keynote speaker, Dr. Jared Marks, is board certified in emergency medicine, a member of the American College of Emergency Physicians, the American Academy of Emergency Medicine, as well as the Society of Academic Emergency Medicine. Dr. Marks is the Director of Ultrasound for the Department of Emergency Medicine, an Associate Professor and practicing emergency room doctor at the University of Nebraska at Omaha. Dr. Marks is supported by the Davis Global Center, where he educates and trains on the Ultrasound Mentor regularly. We are grateful for Dr. Marks's dedication to teaching point-of-care ultrasound and sharing his expertise today. His passion for this topic, alongside his teaching style, will make this webinar both educational and enjoyable. So take it away, Dr. Marks.
No, you are muted.
Thank you. So thank you for the introduction. One of the hiccups of doing this remote learning at this time. In fact, we had a little struggle where I had trouble finding my link to this morning. And so I'm sure many of you have gone through similar hiccups as you try to do remote education. So I just wanted to give you a little introduction about where we're at. For those of you that are in the US, know where Nebraska are, many others may not if you're outside of the USA. So we're kind of right in the middle of the country. Often this is referred to the heartland. And we are at the University of Nebraska Medical Center, and that happens to be our academic institution. And then we have Nebraska Medicine, which is our clinical institution. And just to give you a background, I'm sure many of you are in similar institutions, but at the University of Nebraska Medical Center, we have several colleges that are doing education and trying to figure out how to do this remote education on an ongoing manner, just as we have been in our department and in the College of Medicine. Clinically, we have two hospitals. One is our main academic center, and between the two, we have about 809 beds. Between our two our emergency department, which covers both facilities, sees about 95,000 patients a year, and there are about 100,000 outpatient visits a year. And then obviously we're training residents and have several subspecialties. This is our Davis Global Center, which does a lot of simulation and education. It's a 192,000 square foot facility with state-of-the-art simulation facilities, something called iExcel that kind of helps us work interprofessionally between us and do a lot of interactive and transformative learning. Allows us to do some virtual and augmented reality. A lot of what you'll see in the slides today will be from the learning that we've done at that facility and the way we've been able to cope with this pandemic and how we do our education at this time. So just to give a little kind of what my background is as far as education, and this being a 3D ultrasound simulator. I'm sure some of you are sharing the similar background, but Point of care ultrasound has been my area of focus that I started with an interest back in residency with great mentors and proceeded to do a fellowship. Since that fellowship, I've ran 2 programs, one at another academic center in the Midwest, and started 2 fellowships, and really enjoy the way that ultrasound helps me to be a better physician, and it really enjoy teaching my learners how to use ultrasound clinically so that they become better physicians. Nothing makes me happier than when they say, hey, look at this great case and this catch we had when they're taking care of patients. And I love to receive those text messages back from prior residents that say, hey, I learned that, or I was able to deliver this type of care to my patient this day from using point of care ultrasound. So I think it's important when we talk about, I want to give you a background of what we do here so that you can understand how we've tried to cope with the difficulties of teaching. So I grew up playing sports and I love sports, and really the approach to teaching that I have is similar to sports. And the reason why is that in sports, I think you have a technical component, which is much like ultrasound, is the ability to be able to perform a study. And then you have the strategic component, or the knowledge base, that allows you to implement that into practice. Much before I started medical school, I was able to coach some soccer beforehand, and was also able to teach golf lessons to youth, and really breaking down things into the very finite ability to perform a skill was something that I learned before I even started medicine, and has really helped me when teaching this to learners. Now, what I'll say is that, when we talk about this being like a sport, really what we're trying to do is prepare our learners to do game time implementation or clinical implementation. We do hope that they're learning as individuals on their own time, that they're studying and putting in that hard work. But what we do as educators is we're trying to teach them the skill development, the tactical moves that need to exist in sports to be successful. And that's what we do as their educators. And how I think of this, as I learn more about education models and education that we provide, really what we're trying to do is take people through these stages of competency. And we want to be able to teach them to go from being aware of what they don't learn to essentially reaching the time that they are so well versed in it that they don't even have to think about it. And I think, at least for me, when I'm teaching residents, I look at it taking them from conscious to incompetence to conscious competence. And that's what I hope to do, but then also prepare them with the lifelong skills to further educate themselves and go on to that unconscious competence. So what we do with medical students here, just to give you a little background, I'm sure it's similar to others. Our school's not real large. It's 130 students a year. And we have incorporated point of care ultrasound into the medical school curriculum. We're not necessarily teaching them how to perform exams, but we're trying to educate them on anatomy and learn how that living anatomy can help them or supplement their care in the future, and really focus on learning that what the basic normal anatomy looks like. This requires that the students scan each other and then they get to perform it themselves. I think that's a good way for them to learn what it is to experience what their patients are going through as far as ultrasound occurs. In addition, we have our residency program, and we have currently 33 residents per year. Our first year class has 12 residents in it. And what we do is we have much like many other residencies throughout the nation, have an ultrasound rotation, which we do a 2-week rotation with residents in their intern year. And we really try to get them through the critical care studies that are defined by the American College of Emergency Physicians. And then in second year, we try to teach them what are considered the time-saving applications. And then in third year, we're really hoping that they have taken this to heart, that they continue to clinically implement it into their patient care on a daily basis. And so we do this through a couple things, just like I mentioned our curriculum. A few years back when I was at my other academic appointment, I started some FOMED. Not being well versed in technology at that time, I started it through YouTube because it was a simple way to disseminate education. And I continue to do that to this day. We also do clinical scanning in our emergency department where our residents scan patients, both as practice and clinical exams. And then we do scan labs throughout the year. Most notably, we do a large session in the beginning to get the residents in their intern orientation month used to doing ultrasound or feeling comfortable with the machine so that they don't have that hurdle to overcome as they're standing in front of a patient. In addition to this, we have a Ultrasound Fellowship. This is a subspecialty within emergency medicine. You cannot sit for a board certification for this, but there is a focused practice designation that is provided by ABEM, and those exams will begin in the next couple of years. So in preparing our fellow for this, we have a 12-month curriculum in which we do weekly scan sessions. We have weekly didactics, and we also have a weekly image review where we sit down and review the clinical studies that have occurred recently. This is a intense day, and essentially I spend most of one day with my fellow going over these things and teaching him or her as we go through. This is an example of our previous fellow. Much of what they do is learning to educate others on directly at the bedside, and then learn education models of how to deliver education moving forward to junior learners. In addition to this, our department runs an emergency medicine course, a rural emergency medicine course each year. We participate in ultrasound in teaching how to do central line access and peripheral IV access with ultrasound guidance, and feel that this helps our rural community here in Nebraska to be able to deliver the care when it may not be so easy to obtain the IV access. Additionally, in the past few years, we have lectured internationally in Peru and taught a week-long course there, and have also had the opportunity to educate in Hunan, China, and deliver some education there. So as far as giving you background, this was all the sticks in the fire that we had over the past years. And then much like you'll probably all experienced in mid-March, everything came to a screeching halt. And this is where we had to really determine how we continue to educate people and continue our mission as a department with educating ultrasound to people both at our facility and elsewhere. This is just an example of what happened. So if we look at the number of training and clinical exams we see over time, I started measuring this back in 2017 when I came to the facility. And we can see that about in 2018-19, our average number of studies that we would perform, this is apart from all other education, this is just scanning in our department, and both being clinical and training studies, we were averaging about 500 exams a month, whereas this dark line exemplifies when we had everything come to a screeching halt for us with the pandemic, and we see that we kind of fell off a cliff there. And that was because we withdrew all rotations. We took all people out of the emergency department unless there was essential care to be given. And so there was not much training that was going on other than the direct patient care that we provided. So the difficulty with this, as many of you may know, is that, especially I see this when I teach ultrasound, is that a lot of people get a little bit of experience and they overestimate their ability to perform something. In other words, they get a high degree of confidence before they develop true competency. And this is known as the Dunning-Kruger Effect. And I'm sure many of you have heard, it takes 10,000 experiences to become an expert. I don't know if that quite is true, but it definitely takes some meticulous training and meticulous learning to be able to do that. I think of this a lot like doing intubations in our emergency department. My residents are actually fairly good at it. They've done more in the past 2 years than I have. The difference has been that over time, as we develop a skill, we become more meticulous in how we deliver that skill. So if there's a difficult airway that they struggle with, because we've done that training and we've prepared ourselves, we're still able to assist and aid them or obtain the airway if needed. And that's the same thing I'm looking for with ultrasound is helping them get to where they develop competency and not so much just confidence. And that's been the struggle since this has began. So I'm going to go through you with some of the challenges we obviously faced. So I have 4 beautiful, wonderful daughters. And at the same time, things came screeching to halt for us. They also went online with school. And the internet is decent for us here, but putting 5 computers on a network trying to all access video conferences at the same time my house was not equipped for that. And so I actually found myself trying to update our modem, update our internet package, and make sure that we all had computers that could access the things we needed. Now, additionally, this is my 8-year-old, and she is our most she's our most active child, and she gets really fidgety. So not only are we all doing this at the same time, but then she's getting up and asking mom and dad to do things as we're working and teaching remotely. I already talked about the difficulties with our internet, so I'm going to move forward. So to add to this difficulty, which we had overcome some of it, in September of this year, our hospital suffered a cyber attack, and that basically shut down everything that we had. And we were working back to old paper charts and documenting. The difficulty for that with us is ultrasound wise is we can look at ultrasound machines, but to be able to deliver remote education is nearly impossible when we could not access our online sessions or our online software management for our ultrasounds here. So jumping back to March and April, what we did obviously as a department is we went to online teaching, which I'm sure many of you have done. One of the things we did as far as ultrasound goes is we were no longer able to have residents rotate in the emergency department. That had a lot to do with availability of PPE. But what we did is we made sure that the residents that were supposed to be on rotation were participating in image review. And we actually invited students, prospective students that were unable to do clinical rotations, both at our university and another university here in town, to participate in image review. So we had gone from in-person image review and education to online. And one of the things we did is we provided weekly readings, and then actually to help them learn some lifelong learning skills, asked them to develop quiz questions that then we would also discuss as part of this image review, and then we would work on specific topics during that time. Additionally, during that time, not being at the university and not having access to some of the charts and things I needed to, I worked a little bit more on developing some FOAMed, came out with some FOAMed for COVID, and then also for other topics, mostly focusing on pregnancy at that time, and tried to deliver those to that education to my residents as an easy way for them to access at any time that they need, not just when I'm available. In addition to this, with the COVID pandemic occurring and projecting that we would be seeing these patients and needing to be best prepared to treat them, I took the research that was out there and available as far as the description of ultrasound findings and prepared a slide handout and posted these around our emergency department. In addition to this, because it was not known at that time how infectious this would be and how much cleaning would be required, we started working on getting a handheld ultrasound device so that we were not having our large ultrasound units being monopolized or shut in rooms for long periods of time or running out of wipes to clean these. One of our biggest ongoing challenges, I feel, not that we don't have great supplies, but I think everywhere is struggling with this, and that is getting new supplies for the PPE. And that is, Currently the fitted mask that I best fit to does not, we do not have any left at our hospital. And so I'm wearing a mask that I've been secondarily fitted to. Obviously not as comfortable for me. And we're obviously wearing shields in our entire emergency departments doing this. In addition, for this, we have a UV light, and we have our mask reutilized several times by using this UV light to clean the mask. By doing this, though, that has solved one of the problems. We've been able to reintroduce learners back into our department. We have students rotating on regular rotations back with us now. But in addition, we've been able to resume our ultrasound rotations and our clinical shifts that our ultrasound shifts that our second years do. And so we've been able to resume the hands-on portion in our emergency department, but that does not come without other challenges at the same time. In the College of Medicine, we used to have large sessions where we had multiple students scanning all the time, and at times we would use standardized patients. One of the difficulties with that has been that our standardized patients are only by the regulations we have at this time are only able to interact with 4 people. So that would be 1 educator and 3 students. When you have 132 students, that's just not realistic. And so as we've tried to come up with ways to work around that, and a lot of that has been moving students to only scanning each other. Many of them did it before, but that's what we have to reshuffle groups when students are don't want to be scanned. In addition, contact tracing has been a big thing. That was something I learned with this. A lot of times we were able to shift students around, and we were able to put them in groups as needed. Now we have them divided into groups of 2 or dyads or triads. And the idea is that they only scan with that group. It's known who they come in with, and we know which providers are teaching or educators are teaching them, so that if there's any outbreak amongst the students, that we're able to do our contact tracing and basically inform everybody and have them watch for symptoms. The first session we were back doing, we did not do that as well, and actually did have 2 students that were then positive. And so we were left scrambling, trying to figure out some of these challenges. In addition to that, as I have residents help with education, I received this text message the day after we had done a session with students. And during that time, instead of having a large group together, we spread them out through the day. The one common factor being the residents that help educate or the staff that are educating that are across those different groups. And so I got this text about one of our residents that ended up testing positive, and just had to make sure that the right procedures were followed prior to that, so that the risk was not there for the students. What we still face with the residency and the fellowship is we're still not able to meet as a group, but we are able to do online education. We are able to meet in smaller groups and more concentrated, but still with 33 residents, that becomes quite difficult. And often, I'm sure many of you are busy, as I am on my administrative days. I find that I'm either eating or wanting to snack previously in meetings where I can sit and be quiet. And now that is not a possibility. And so that makes it difficult just as far as time management in a day for me now. What we've done to overcome some of this, obviously, is we break up in smaller groups. We've done some simulation days. We're fortunate enough to have the Davis Global Center, where we have several ultrasound machines. So we're able to isolate those to small groups, and we're able to use different simulators to educate our residents on the different things, so that not many of us are going into the same patient's room over and over as we do education, and especially not spending significant amounts of time in a patient's room that may or may not be infected with COVID. To compare this to what we did last year with some of our education, one of the big events that we do is our Intern Orientations, as I discussed before. And also we do a Sono games. We do gamification for our residents. And if we look at 2019, we were all able to be in a big, large room. It was very loud and boisterous because, people were harassing each other, giving each other a good, having a good time, laughing. With the different things we were doing, is we made this, try to make this fun. compare that to 2020, we had to basically go from one single room where everybody was able to be in that room to a floor of our Davis Global Center, where they were broken up into groups of 3 and 4, spread out, had to do a specific rotation through the area to be able to isolate groups and not get them cross-contaminating if anybody were to be infected. And I think the hardest thing with that education was just being able to give good, quick feedback on some of the things that we were providing to them at that time. Obviously, one of the things we're able to continue to use during these type of events is our simulators. Here we see the 3D ultrasound systems as we use that for education for our transvaginal ultrasound. And I think we're doing pretty good at returning to that. Obviously not back to our normal, but doing that. One thing that we're still struggling with is that we have not been able to resume community education with our planned rural emergency medicine course. Our international endeavors are still limited. This year to provide international education, actually with the difficulty of doing time zones and Zoom between the international countries, we actually did some recorded lectures and provided those to the hospital in China, where they were able to translate this for us and provide that ongoing education there. In closing, I just wanted to show you, I know Rand's going to get to showing you how this model works, but I thought it would be interesting to see how well their system projects what COVID looks like, since this has been the big thorn in our side. On the left, you have the simulator, and on the right is a patient who is with COVID. The comparison here, the patient on the right is a more severe case. This is a patient that had oxygen levels in the 50s, was on 80 liters of oxygen by OptiFlow. And so a little bit more severe compared to the model I pulled from the machine, from the 3D ultrasound systems. And here's just another example of it that we'll get to a little bit. So these are B lines that we'll talk about, and irregular pleural lines. And we see this irregular pleural line right here. Again, if you'd like more information about the Davis Global Center, that QR code will get you to that. It's a great facility that we have, and I believe long-term goals are to do some outreach education. Sorry, wrong way. And if you have interest in seeing some of the FOMED videos and education I put out there, you can also scan this QR code. I appreciate the help from those at the Davis Global Center in preparing this, and also those at 3D Systems. Thank you.
Okay, so thank you, Dr. Marks, for this wonderful presentation. So my name is Ran. I'm a product manager of the Ultrasound Mentor in Simbionix 3D Systems. And I'm going to tell you about today our latest innovation, which is called the cloud simulation. So what is cloud simulation? It's an online interactive course for learning and practicing ultrasound using cloud services. The big advantage of this innovation, of this technology, is that you can basically run it from anywhere you want. As Dr. Mark mentioned, there are so many challenges because of this pandemic, the COVID-19, and basically you can run it from anywhere you want. The only thing you need is just an internet connection and a mouse that it uses as your probe, and you can basically run it whenever you want from your home. It's important to say that this need for this technology came mainly from the field. Many of our customers approach us and mentioned that they need a solution for when the sim centers are closed and they want they can't reach the simulators, and they need a training solution when they are working from home. We know that this can't replace the real feeling of the ultrasound probe, but it gives you another layer of structural training that basically for learning views, learning the anatomies, and then afterwards you can go to real hands-on training. So you can see my screen right now over here. We'll start with the demo session. And what you're seeing on the screen right now is the Mentorland management systems. For those of you who are not familiar with Simbionix product, Mentorland is our management system for all Simbionix simulators. And the model I'm going to show you today is, as Dr. Moss also showed the video, is the COVID-19 model. A little bit about the COVID-19 model is the model that we released in last March, around when the pandemic started. We got a lot of evidence from physicians that tells us that they're starting to using lung ultrasound to diagnose COVID-19 patient, and there is a real need for training lung ultrasound. So we developed this model with a number of key opinion leaders. If we review this course, we can see that we have all kind of excellent didactic material. For example, about the lung ultrasound basics. Let me show you an example for one videos. We have videos about the typical findings that you can find in COVID-19 patients. We have disinfection protocols. We have also an echocardiography section about the role of echocardiography. And as you will see, all our courses are really built in a very structured way. We always start with a tasks that guides you in a step-by-step approach how to reach the standard views, according to a protocol. For example, here in lung ultrasound, we are using the blue protocol. And then we have a case of a healthy patient showing how to scan a patient without any symptoms. And then we go over to the more complicated cases that shows patients with all kinds of symptoms. We have a mild, moderate, and a severe case. So I will show you the one of the cases of the moderate COVID-19 patient. All cases start with the patient file showing the medical history and complaints, showing a little bit about the physical examination results. And then you can run the case from here. I already run the case from advanced. So you can see over here. Let's put it on the screen. So what we are seeing here, first of all, we can see the ultrasound image over here. We can see here the 3D anatomy map showing the map, and we can see the probe traveling over the surface body. So how do I manipulate the probe? Using only my mouse that I have here with me. Simply by, for example, if I want to scan the lungs over here, I'm using the right click to go over the entire surface body. I can rotate the probe using the wheel mouse. And I can also do all kind of tilting with the probe. Basically, how you use a real probe, you can do all the things that you can do with a real probe only with using your mouse. Let's talk a little about the all the different possibilities that you can do in the simulation besides going with your probe. On the left screen, you can see the toolbar showing all the ultrasound machine options. You can switch, for example, from abdominal probe to a cardiac probe. You can change, for example, the depth of the image. You can apply gain contrast if I want to change the gain contrast of the image. Basically, you can do whatever you can do in the ultrasound machine. Another section we have here is the record and analyze section. Over here, I can freeze, for example, the image. I can play it frame by frame. I can also do all kind of measurement. And in the end of the case, I can also report my clinical findings. When I found here, each sector, and I can also report my suspected diagnosis. For example, in this case, I can report pneumonia, for example. And the cool features that we have over here are over here in the middle. For example, those are educational features. For example, I can hide the rib shadows. This can really help me when we wish it will happen in real life. But here you can turn off the rib shadows, and then you can really see a better explanation of, for example, here of the B lines. Another things we can do, we can turn on anatomical labels to better understand the anatomy. For example, here I can see a better understanding of the heart for really beginners that want to learn how to use the probe and understand the anatomy. Besides 2D mode, we have also other modes, for example, M mode that can be seen over here. And in other modes, we have, for example, modes like color Doppler and pulse wave Doppler. And all of these modes are, of course, embedded in our ultrasound simulator, but are also available in the cloud simulation. I want to talk about now the 3D anatomy map. I can also, this view, I can, of course, rotate, manipulate all over, however I want. I can do a cross section, for example. Also, it's better for understanding the exact sector I'm seeing here. I'm also going to see it over here. I can do can link the image, for example. And then I can see exactly what the probe is seeing is exactly what I am seeing. And over here, we have this part showing us the standard views. In this set, the different sector zone. And for example, if I will switch to right under inferior 2R, I can see also the drawing that teach me exactly where this area is located. And we have a nice feature called the ghost probe that teach me exactly how to reach it and where is this area located. And once I reach it, it turns blue, as you can see over here. Really teach me the exact anatomy. So what I'm going to do now is that I'm going to invite Dr. Max to help me in this section. And this is a very nice feature that we can do in this technology, that you can have a proctor guide you through when you run in the simulation. He can add annotation, he can do a remote control and even control my probe. And this is really nice. You can use any video conference software that you may have. We are using now Zoom, but you can do it in every software. And this is what we call the proctor mode.
Yeah, let me
so
turn on
yes,
my
Dr. Max.
annotation. So one thing I want to point out here is we unfortunately, or this is obviously a new technology. We have one of the comments in the chat is that they have a Symbionix system and how do they get access to this? We also had this at the time of the pandemic, but due to the isolation we had, we weren't able to do this. I think this is a great way to deliver education when we have these type of things occur, just because having these models would have definitely supplemented the education we continue to do. So Rand, why don't you select down here, right here, the right, the R1.
Yeah.
And then
Okay.
let's put the probe in that spot.
Yes, okay.
The nice thing is it gives you a idea where the probe grows. This also happens on the system if you have it. But what we can see here is our rib shadows. Our rib is here and here. This is our pleural line. And from this, these are called comet tails or B lines, most accurately called B lines. And those are signs of interstitial fluid or edema, and that's buildup in the lung of fluid. It's a finding that you can see in many pathologies in the lung, but it's also it's one of the findings we see even in mild disease of COVID. And it's important to be able to recognize that because X-rays will not always, this will be more sensitive and show up earlier than an X-ray. So, you know, teaching this skill is helpful to our learners. Why don't we try the, can you show us the area? I think it's right in here that has the irregular pleural line.
Yeah, and you can see here the subpleural consolidations.
So no, I took the images for that comparison before from the moderate diseased. And this is the module that I borrowed those from, and I actually pulled up and then I had a severe disease for comparison. So here's their irregular pleural line and the B lines coming along with it. Again, we have our ribs here because the video is moving, but you'll see them and they kind of dip right in there. That is our irregular pleural line, which shows a little bit more advanced disease or more fluid within the interstitium of the lung. And then maybe just show them a diagram.
Yeah, sure.
So in COVID, especially, not that we're doing education on COVID, but they don't typically have very large pleural effusions if they have them at all. And so we can see an example between these ribs that there is a little black space, which may represent a very mild case of an effusion, which would be typical of our COVID patients that we're taking care of. And I don't want to get distracted and say this is only for COVID. There's plenty of other modules that they have. And we actually use them for training in person on our simulators, but having it online is going to be a great advantage to be able to deliver this education.
Mhm. And so what is the diagnosis of this patient, for example? What do you do with this kind of patient comes to you?
Yeah, so I mean, that's the hard thing is none of these findings in lung ultrasound, none of these findings are specific to COVID. These can all be progression of disease and many things. So a lot of infections will look the same as what we're seeing here. Obviously, the worse they are, the worse the disease is. And so, you know, even in that flyer that I had developed before was to show people that B lines are the first thing you'll see. And then irregular pleural lines the second. And then something called air bronchograms that's not displayed in this model, that's usually more severe, is a later finding, and those will be those that are typically having more difficulty. And as we know in COVID, that much of that is just it's an acute respiratory distress syndrome, and those are the same type of findings that are shown in those.
Yeah, so actually we have in the severe case, we have also showing a large consolidation with the air bronchograms.
Yep, you do. I've reviewed them all, and they're a great example of what you'll see.
Yeah, and maybe we can discuss, we have also some cases of the echocardiographic cases. Maybe you can refer to cases that may be seen of an echo related to COVID-19.
I mean, I think it would be great to show them your module on an echo. I think pulling up one of those would be a great idea. There is obviously in sepsis and infection, there's varying models as far as what the heart does. Initially, it's very hyperactive and has a high output typically. And then as it progresses, they can progress to a cardiomyopathy. We're going to look at an example. I think you put a pulmonary hypertension. Unfortunately, I have seen that similar findings in my COVID patients. Unfortunately, they're not the ones that have fared well with the disease, but they will have some of the findings we'll see here.
Okay, another thing you can see that the simulation has that you get all kind of messages on the screen that teach you step by step how to use the simulator.
I think the best view is probably an apical if we can do that. Yeah, just the 4-chamber would be great. So I think the nice thing is it puts the probe there for him to go find it and look at it. And then we can see the image of what he's getting. I played around with this. I felt like it was a pretty steep learning curve to learn the functions. On my mouse, I use a Mac mouse, and but felt I was able to get it and learn it quicker the more I did, obviously.
Take up the group shadow for now.
There you go. So this is just an example, which we see here is usually a RV. So this is, let me keep moving my thing, but not showing you. So yeah, he's got it labeled there, great. So the RV is typically gonna have be about 60% the size of the left ventricle, and that's normal. It will look quite a bit smaller, or it's 0.6:1 ratio. Here we see that the RV is getting quite dilated. Fortunately, it still has pretty good function, but in the patient, so this is typically something I don't see. It's more develops in the ICU, but I have had patients present with significant right-sided heart failure due to the amount of fluid in their lungs, and that's not, from my experience so far, is not a very good sign for the patient. But this can give you an example of what different findings in seeing that disproportion on the right ventricle to left ventricle for your patients you'll be taking care of. Will be.
Yes, and in this case, we can also do a measurement. By the way, we have all kind of measurement available. For example, in this case, you would probably do a right ventricle, right, an area or a diameter measurement. Dr. might probably measure the right ventricle size.
Yep, that would be great. If you want to do it to show that, that's great. I don't think that we necessarily need to go through every measurement, but I think just the function start, it would be great.
Yeah, so I think we can move on to the questions, Q&A. So we'll check now the question. If you have any questions, please feel free to ask us. And as we said in the beginning, I think Michelle said that if you want to hear more about the prices and costs, and please leave your email. We will be happy to send you a quote and maybe more details.
Yeah, Ron, we have a lot of questions in the chat section about getting access to these online modules. And so our team will gather the information. Please put the educational or professional institution or facility you're associated with so we can match you with the right team member. So you can get more information. And we also can schedule at any time a virtual demo for your program that includes this remote version, or just simply the traditional ultrasound mentor without the online version.
Yes, exactly. If you have any clinical question as well for Dr. Marks, please free to ask. So, while you're asking, I will continue playing with the model. You can see over here, I can apply a color Doppler, apply a post-wave Doppler. Any of you that are familiar with the ultrasound method probably know all these capabilities that we can do. Everything is available also in the cloud simulation. This is show how you move the virtual probe with the mouse. Okay, so I have the mouse over here, and we have also here available the exact instruction how to use. So I will explain it just again. Using my right click, I can move the probe all over the body. You can see it over here, the probe traveling. I have another degree of freedom, which is the mouse wheel, that you can just rotate it, the mouse wheel, and then you can rotate it similar how you rotate the probe. Of course, it's something that you need to learn a little bit at the beginning, but once you get it, it's very intuitive. And the other degree of freedom that we have, we're using the left click, is that I can also do like tilting.
Dr. Marks, we had somebody who was interested in seeing your YouTube channel. Would you be able to share that link into the chat section?
Yep, I can do that.
Also, somebody I see would like a demonstration for the OBGYN module, which we didn't cover today, but do you see training needs for the emergency department on the gynecology or OB side of things?
Yeah, I mean, for us, I think so we do a lot of practice scanning in our department where our residents go introduce themselves and say, hey, you've had this study done. I would like to perform the same study, or, and if they've had a similar study, like maybe a CT of the abdomen, then they say, I want to look at your gallbladder. Then they compare the images, and that's kind of how we prevent there being safety issues with our training. But one of the most difficult ones to approach patients is especially transvaginal ultrasound. So using simulators to represent that is, ideal, because it gets people comfortable with the anatomy, gets them comfortable with recognizing some pathology. I think one of the limitations for learners using ultrasound in front of people is that they struggle with the machine, or they struggle with the anatomy, and then they feel uncomfortable, and that feeling of being uncomfortable prevents them from doing studies. So using the simulator, especially in OB, for us is helpful, and that's how we teach the students. OB is on the simulators, so very helpful.
Okay, see what else.
I opened a can of worms with the OB question. Do we have specific modules for neonates? Do you want to speak to that, Ron?
So we currently don't have something for neonates. We are working for also pediatric models in the future, but currently it's still in development, I can say. Okay, so I think there is no any other questions. What we have here, cranial ultrasound, also not at the moment.
Ron, why don't you go out to the main list? I think that shows pretty well what you have. That may be helpful.
Yeah, of course. So over here, we can see all the library of Symbionix models. Of course, you can find all the information in the Symbionix website. So in terms of ultrasound models that we have all kind of a focus model for bedside echo, EFAST. We have abdominal, we have TEE, advanced echo, lung ultrasound, neck ultrasound. In the OBGYN, we have again, a basic skill model, a basic GYN. For OB first trimester and second trimester, we have a model as well, a fetal echo, ultrasonography. And our latest innovation, if you may heard, we have also ultrasound guided intervention simulator. So this is the first virtual reality simulator for ultrasound guided procedures. So we already have the thoracentesis model and central line placement. So again, if there's something that interests of you, please leave your email, and we'll be happy to elaborate more details about these models as well.
Okay, we're down to the last 5 minutes. If I don't see any other questions come in, I have a question, Dr. Marks. Are you seeing an uptick in emergency physicians using the transesophageal echo? Is that a trend you're seeing? And do you have any thoughts on that for this group?
So yes, absolutely. We currently do not have TEE in our department, but that's occurring at a lot of academic facilities. I'm not sure if it's happening in many community settings, but as we prepare to do a proposal to obtain that, we'll be using simulators to also help us prepare ourselves. So.
Okay. Last call for questions. I just want to thank again, Dr. Marks, thank you so much for lending us your expertise and your time. I highly recommend to everybody to check out the YouTube channel. It is a remarkable site for advanced learning to just very early learners as well. Ron, thank you so much for all your dedication and work to not only the Ultrasound Mentor, but building curriculum and meaningful interaction with learners remotely. It is humbling to see what you and your team have been able to do for this product and for all of our educators and facilities around the world. I don't see any more questions. Any final thoughts, you two?
No, I think using this, well, just for education, I think this is great. I'm actually headed to a shift right after this and we'll be implementing this with my learners. And I think, you know, preparing them, like I said before, like a coach helping, anytime you can have something that teaches them the medical knowledge and exposes them is going to be great. And I think this is something I wish we would have had back in March. Would have made my job a lot easier.
All right, so I'd like to thank as well to Dr. Marks. It was really a wonderful presentation that you showed us, and that's it from our side. Please leave us.
Thank you, Olivia and the SSH for this amazing platform to connect people from all over the world to experts and powerful simulation education. Thank you very much to the SSH and Olivia specifically.
Thank you, Michelle, and thank you, 3D Systems and Dr. Marks.
Thank you. Have a good one.
Have a wonderful day.
Bye-bye.